Dr. Harry Jacob. I'm the Chief Medical Editor of Hem-Onc Today, and we're pleased to have one of our younger board members of Hem-Onc Today, Dr. Mark Stein, who's going to discuss with us some issues in prostate cancer, its treatment, its potential non-treatment for some patients. Dr. Stein is at the Dean and Betty Gallo Prostate Cancer Center at the Robert Wood Johnson Medical Center and the Cancer Institute of New Jersey, and is a board member of our genitourologic malignancy section of Hem-Onc Today. We're pleased to have you with us, Mark. There seems to be a never-ending questions about who needs treatment, who doesn't need treatment for probably the most prevalent cancer that we have in America, and certainly in males, prostate cancer. And I wonder if you could kind of just catch us up on some of your thoughts about who should get treated. What are the decisions that doctors ought to be making with their patients as to who might benefit, who might not benefit from the kind of toxic therapies that can be used? What's new?
Sure. It's a good question. And obviously we know that it's a very common disorder, prostate cancer, approximately 220,000 cases that will be diagnosed in the coming year. At the same time, we know that there are only a relatively small proportion of those men, fortunately, who will ultimately die of prostate cancer, approximately 27,000 deaths per year. Now, the challenge is to figure out of those 200,000 cases who does need treatment and who doesn't. And over the past decade and even in more recent times, we've been able to start to distill some of the features that do predict for men who do in fact need more aggressive therapy. In a number of clinical trials now, we've seen a recurrent pattern, both a Swedish trial, American studies, where we've looked at, particularly in the Swedish trial, observation versus some sort of intervention. And it does seem that there is a survival benefit, particularly in men with higher Gleason grade tumors. So the Gleason score over and over again, right, which is the pattern that is seen when the prostate is biopsied, that a higher grade tumor there seems to be an important factor to take into consideration when deciding on observation versus active treatment. Nevertheless, there is obviously a very large population of men who have relatively low-grade tumors, and yet still carry the weight of a diagnosis of prostate cancer. And it's really that group in particular, men with lower-grade tumors, or even some older men where they have a medium-grade tumor, where there really is a significant question about whether or not any sort of treatment is in fact ultimately going to be beneficial. These men include men with Gleason grade 6 tumors, some older men with Gleason grade 7 tumors, where it would seem that only a relatively small proportion of them are ultimately going to die of their disease. And then, as you mentioned, there are obvious concerns regarding the morbidity of local procedures, and it doesn't make a difference what local procedure it is. None of them are wholly benign, and so it's those groups that there are a number of initiatives now that we're really trying to start to focus on.
What's your hope for brand new concepts that don't require microscopy, which in so many other areas really we're getting away from? Obviously, genomic signatures and so on. Would you predict they're going to become an important assessment of who should and who shouldn't get treated?
We are starting to try to pick out different molecular signatures that will in fact predict for more aggressive disease, though unfortunately that's still in its early stages, because the natural history of the disease is so long that to really develop a robust database where you're going to be looking at a gene profile and then ultimately correlate it with outcomes is something that we certainly aspire towards doing. The field is not quite there yet. For men with localized localized disease, but that is an important question. But there are some additional features. There's recently a very important protein. It's a fusion protein that's found on chromosome 21 between a gene known as TMPRSS2 and its fusion partner is ETS. And this is a molecular signature that might be found in somewhere between 50 and 70% of prostate cancers. And this is a fusion protein that was only identified relatively recently in 2004, and it seems like it might predict for a more aggressive course.
That's present in the tumor, or can you assess it in the serum?
No, that's actually present. Well, for now, interestingly, it's there are some recent papers that have looked at assessing it in the urine as a potential molecular marker. So this is a very interesting and developing area. Obviously, there are a number of groups that are trying to look at more robust PSAs, both autoantibodies to PSA, other molecular markers that are secreted by prostate cancer instead of PSA. So that's sort of a whole separate area that is moving forward at this time.
So if I can summarize what you said so far, we're still kind of by guess and by gollying who should get treated and who shouldn't. There's certain obvious patients who should.
Lawrence Klotz at the NCIC in Canada is spearheading an important trial that is going to be looking at choosing any sort of therapy that a patient, whether it be radiation therapy or standard external beam versus brachytherapy or surgery, and patients will be randomized to either intervention with one of those modalities versus observation. And that's a trial that's going to be getting off the ground shortly, and that we're really looking forward to having robust participation in, so that we can definitively answer if patients really need to have treatment in a definitive setting versus observation. And this is called the START trial, and is launching shortly. I think they're going to be answering important questions.